Hi everybody, there's a lot of you at the back. Is anybody, you all happy there? I'm a nurse, but I'm not scary, although my colleagues might beg to differ. Just wait for people to arrive. Go for it. Yeah.
Okay, we'll move on to the second talk for the afternoon session now. I'd like to introduce to you Claire Tucker and Sally Bazady from the University College London Hospitals NHS Trust. They're going to speak to you about identifying gaps in service by assessing patients against NHS England's discharge ready date criteria. So without further ado, over to Claire and Sally.
Thanks very much. Hi everybody, so I'm Sally Bazady and I'm a nurse by background, been a nurse for about 25 years, worked for 20 of those at UCLH, background in GI nursing, and I moved into patient flow about 7 years ago, which is absolutely my passion. My boss yesterday was talking and she described me as one of the two Miss Marples at the Trust, and to be a Miss Marple you do need to know about data, so that's why I'm here today.
Hi, my name's Claire Tucker. I'm a senior information analyst and I've been working at UCLH for around 10 years. I started in the workforce information department and then I moved into performance, focusing mainly on report development. After the implementation of our electronic healthcare record system in 2019-20, a corporate analytics function was set up in the performance department to try and focus on turning this huge new influx of data that we had into usable organizational insights. So I'm currently working in this team and alongside Sally, working exclusively on patient flow.
So a little bit about UCLH. We're a big central London hospital, local population about 1.4 million, but we're a tertiary centre for some of our services, so we see people from all over the country, in fact, from all over the world. We employ a lot of staff, nearly 12,000 staff, and have, I can't remember how many, 848 inpatient beds across 7 inpatient sites.
So today we just wanted to share with you a little bit about how we think our relationship works really well in setting the basis for improvements in patient flow, focusing on delay data specifically around patients staying in hospital and acute beds beyond their discharge ready dates.
Thanks, Claire. Discharge ready date and criteria to reside has been talked about a couple of times before, so we just thought it was useful to put the definition up. Discharge ready date is really when the doctor says that patient no longer needs to be in an acute bed, and the criteria to reside assessment is a daily assessment which we conduct on every adult inpatient across all of our sites to, against a set of criteria about the care and treatment that they're having.
So where did we start? We decided that we were going to focus in on the calendar year 2023, so I pulled the criteria to reside data and measured the bed patients that inpatients were spending in acute beds across the trust, so after they'd been declared medically ready for discharge. I expanded this data set to add on our information from our integrated discharge service, split by the discharge to assess pathways, and then I separated the potential analysis of the data itself into 3 separate areas, 3 separate methodologies. So you can see here that the blue bar, that's just a simple midnight count of patients staying beyond their discharge-ready date in an acute bed. The red bar is a minute count analysis taken from a reasonable time after they were declared medically ready for discharge, and the orange bar, the yellow bar, is a more complicated calculation that we looked at by admission type. So in order to just sort of hone down the best way of looking at this data, we decided after discussions that we'd go with the red bar. We thought that the blue bar might be overcounting and the yellow bar might actually undercount some of the delays that we're looking at.
Sorry. So just to say, discharge to assess pathways. Nick this morning talked really well about some of the more complex discharge patients. We don't have control over those. What we want to do was look at the patients that we could maybe influence and where could we internally within the trust reduce those bed delays. So looking at those pathway 0 patients and some of the pathway 1 patients as well.
So you can see here on the chart, if I highlight these less complex patients from this data set, we're looking at around 21 beds or so of data that we can drill down to and try and assess if we could make any improvements. So I broke this information down into delay reason groups and pulled together some underlying data. Sally and I got together to see where we would go to next. So you can see, sorry, just to explain this chart, you've got the days delay from 2023 at the bottom for all pathway 0 and pathway 1 patients, and the reason groupings along the bottom.
Claire said in her introduction that we work closely together. We have a weekly catch-up huddle where we might talk about all kinds of things. To be honest, often it's something that NHS England or our local sector have forced upon us to look at very quickly and at pace. And there's generally a presentation that I need to give to somebody about what's going on. But when we have more time, what we like to do is either Claire brings me some data and says, let's look at the pattern of that, or I say, Claire, I'm really concerned or really interested in seeing what's going on here. That's my Miss Marple bit. You know, how can we work on those two things together? We always want to make sure that it's not just us, where we can get other stakeholders together if we've got key questions for them, and making sure that we always feed that back as well.
So we generally do a lot of brainstorming around this data. We discuss what other variables it might be useful to bring into the data set for an exploratory analysis. And then I will go off and pull these data sets together and churn out lots of different charts. So I typically use SQL, Excel, note searches, any local information that Sally's given us. I talk to people that she suggested on her side might be useful, and I speak to people in the data units that I work among to see what kind of information is out there that they might be aware of. So for this particular project, it seemed like a good point to start investigating the use of R, which is where my sort of data science journeys began in a bit more in earnest. So I decided to apply this to this data set. So here you can see the top 5 reasons, which are patients delayed awaiting investigation or test, therapy, awaiting input to go home, other or medical decision. And together, that comes to around 17 beds. We want to show you 4 examples of how we work together, looking into this data and some of what we found. So the first thing that we looked at here is patients who are delayed because they're waiting for tests and investigations. And you can see here that I've used R to generate some information so we can look at this in a bit more detail. So unfortunately, the free text data entry around the type of test that we're looking at or investigation wasn't really in a state from this particular criteria to reside review data to actually group the data in that way. So instead, you can see the chart on the left. I've grouped 80% of the data, which is the bulk of the data. I've split it into the specialist areas, starting with the highest group of patients at the top, going down to acute medicine at the bottom. So neurospecialties had the most amount of patients that were being delayed for this reason. The x-axis shows the days between discharge ready date and discharge, so essentially the amount of delay days that we're looking at. So the first thing that we noticed when Sally and I came to look at this chart, still the chart on the right, is that the areas that perform best in this respect appear to be the areas that are circled here, so with a short interquartile range and with a low median. So looking at these 3 areas, we noticed that these are all specialists that live within one particular site. So I decided to split the data again, looking at the chart on the right by site to see if this bore out. And it did. So those 3 areas come under our neurology hospital, and we thought perhaps they're performing differently, and there's some good learning that we could take from this area and spread it to our cancer area, clinical pharmacology areas, which have a worse turnaround in getting these delays down. We know that there'll be a lot of variation in tests across these sites, but we also know that there's a lot of the same tests are happening and that there's variation in how these requests are processed and handled.
Our neurology site is a fairly small site. It has a lot of patients, but often the investigations would be similar. But also they work really closely. They're a really close community. And maybe what we've found out is that actually they escalate amongst themselves, so they know what the expectations are, and they work really well as a team. There's definitely something to learn there about escalations. Escalations in patient flow are so important. We should never just accept that something's going to take a long time in healthcare. That's not good for our patients. So actually, when you hear that something won't happen until tomorrow, the day after, next week, we need to always be checking and seeing what we can do about reducing that time.
So moving on to our second example, as we were looking through the free text search on the previous cohort, we noticed together that there was a lot of references to cardiac patients being delayed waiting for investigations and tests. As we expanded out looking at the free tests in other reason areas, we also noticed that these reasons were coming up quite a lot. So I decided to take the full Pathway 0 and Pathway 1 cohort and do a generic notes test on keyword against the patient notes from our EHRS system. Almost a fifth of the patients delayed on these two pathways were potentially relevant to cardio-related delays. So we decided to delve further into that.
So UCH doesn't have a cardiology specialist service anymore. Our patients go to another trust, and that in itself, that handoff between two organisations can of course cause a delay. We also have to take our patients back once they've had treatment. That can cause a further delay to patients further on that we need to do swap beds with, things like that. So we're working closely with the managers on site who deal with the other trust to make sure that we're doing all we can to again escalate, help those patients, make sure that we understand and we're working to all the SOPs and SLAs that we have within that service. Oh yeah, sorry, this is me, isn't it? We wanted to really look at therapy. So therapy can often be seen as a bit of a delay to get patients home, but we need to make sure that patients are fit, therapy fit, as well as being medically fit. And sometimes that safety issue there can keep people in hospital longer. So we really, what we were expecting to see was sometimes patients staying beyond that medically fit date, needing therapy, but seeing if we could maybe send them home earlier with our hospital at home, our virtual ward service, to see if we could really impact therapies with that.
We also thought that perhaps the therapy input wasn't being identified early enough in the admission, so I decided to pull some info from our safe discharge planning assessment, SDPAs for short. So I cross-referenced the data that we have with this information, and I grouped it into the time periods by which point in the spell the patient actually receives their SDPA. We thought that perhaps there would be more delays if the SDPA happened later, but this information at this level, just this very high level data, didn't bear that out. So you can see the delayed patients on the y-axis, and then the groups of 24 hours plus no review across the x-axis. The groups are split into broad admission types, cancer, medical and surgical, and split by elective and non-elective. So although what we expected to see didn't really happen, we did notice that there was something strange happening here. So for our surgical elective patients that were delayed, there seemed to be a huge group that were actually having no SDPA review. So we thought we'd delve deeper into this, and we actually found that most of these patients were coming from one particular ward.
So the process for SDPA is you assess on admission, and it tells you what the patient's likely risk is to go home around safety on discharge. For these elective patients, they all go through surgery school, so that's done with a therapist. This information is really captured with a therapist before they come into hospital. So you could say that doing the SDPA was a bit of dual entry, that it may not be a good use of people's time. But what we're starting to look at is there anything that's missed, either by a therapist in surgery school at pre-assessment, or by nursing in the SDPA, that we should make sure that are covered in both places. It's one of those situations where a mandatory piece of documentation may not be the right thing and may not fit for all patients. But we're really starting to look at that to make sure we're not missing anything there.
We really thought that that was a nice example of how when we put our heads together and look at one particular type of data, we notice something else, and that gives us somewhere else to drill down into. So the fourth example that we wanted to show you is returning back to the graph that I showed before, which has our reasons data. And we wanted to highlight transport, which is this highlighted bar here, which actually shows from the 2023 data that there's around 2/3 of a bed could have potentially been saved had we tightened up processes and getting patients out quicker in this area. However, we know that this is not really a true reflection of the delays caused by transport, because Sally and I have both worked extensively on other sets of transport data. So I think it's quite important to sort of use other data sets as well when you're actually trying to draw high-level conclusions and before you sort of start digging too deeply.
Thanks, Claire. It's a really good example of where what we think is going to show doesn't show, maybe because of data input. In this case, our criteria to reside assessment is completed once a day. It's normally completed in the morning. It's one of those tasks that nurses will complete as part of an MDT, but often they want to get it off their backs. They want to tick it off, so they get it done. So a patient may not have a delay in the morning. They may still meet a criteria to reside in hospital, or it may be a different reason. They're waiting for something else. But the way our transport works, by the end of the day, our capacity for transport, we do not have the capacity. The demand to get people home is there. We have a heavier, less mobile population who need ambulances to take them home. We want to free up those beds, but we were seeing regular delays for several hours and often overnight with that. So it shows how sometimes the data doesn't show you what you want to do, but then we're going to use the data to then show making an impact. I want to say a big thanks to our transport provider who've worked with us on this to try and make that impact. And so we're currently on a trial with that provider of moving towards a booked transport model. So currently, or pre this trial, if a ward needed to get a patient home, they'd book when they thought the patient would be ready. Transport would then have to send patients to all over North London, could be all over the country, when we asked for it. Transport are now saying for local patients, they'll tell us when they'll have that transport available, and we need to have everything ready for that. And you can see from the limited data, because this trial is ongoing now, we're only in the second week of this, but we're already seeing really positive impacts. Helping patients get home before midday is such a big thing for us. Helping patients, telling patients your transport will be here at 10 in the morning, and it actually is. I can't think of when that last happened. And to have not had any delays overnight, so keeping patients in hospital simply because we couldn't get them an ambulance home, hasn't happened in the last couple of weeks. So we're now going to be able to use the data to show this, which will have a massive impact. Oh, is this me? Sorry. So I am not a data person. I like a graph, but I always say to Claire, you need to show me the impact of something in the time it's going to take me to boil a kettle. Because if I'm a ward sister and I need to look at data, I don't have time. I'm really sorry, everybody. I don't understand R or Python or anything like that. But I can read a trend, and I can look at something and see if it's having a positive impact. So our informal way of working really has helped us look at the things we want to look at and then build what we want to do around it. It's a really good way of working together, and then also involving those key stakeholders to make sure that we involve those clinical teams or those support services teams as well.
From my perspective, having access to lots of different sources of data, both qualitative and quantitative, has really allowed me to be able to flesh out the pictures that we're presenting back, not only as we're having our discussions and trying to understand the data, but actually in communicating that back to the trust and to different groups across the trust. It's also allowed me a lot of personal development in terms of learning and applying new data science methods. As I said, with R, which has been opened my eyes massively to the potential for analysing and visualising data in different forms. And I just really want to say thank you to Zella King, who I've been working with from UCL, who's been a fantastic resource in supporting and encouraging that. And I'm building into my PDP after this exactly how my sort of data science journey will move on and how I will be able to apply it to improve flow and to continue working the way that we are.
So we definitely need to do some more training, making sure that we're capturing the right reasons that for patients that don't have a criteria to reside, and also to tell people, clinical staff who are inputting that data, that yes, we do use it, and yes, their input does have an impact, because it can just feel like you're just feeding the machine, and I'm really keen that people understand that that's not always the case, We also want to continue and build on those links with clinical teams internally and externally. It was really interesting thinking about how we could use this with community bed providers as well. So this is stuff that we want to continue and build on.
And from my perspective, it's really important that we formally embed the current way we work. So we know that it works well, but that we want to make more time and formalise how we do things. So we've set aside more face-to-face time. Sally is always on site and based in a different site than I am, and I work from home quite a lot. So we're going to do more planning to spend time together to go through the things that matter. With the information that we've been able to kind of demonstrate that is valuable to us and that needs our attention, I've been able to negotiate an update to my job description to be able to build in more time to do preventative analysis rather than just knee-jerk, and actually having that time to go through things and to learn and to progress in that way. Thank you.
Thank you. That was a super interesting talk. Really nice to see the relationship between the data and the analytics with real implementation
You should
in
see
the
us with a
hospital.
glass of wine as well.
Yeah. There's been one question that's come through on the Slido, so I'll start with that one and then I'll open it up to the room if that's okay. So the first question that we've got here is, do you have any advice for analysts to communicate findings and data better? Anything you've learned from the feedback loops between data and clinical teams?
So from my perspective, that is the highlight of us working in this way. It means that we're constantly, we've developed a safe space with one another where I can repeatedly ask Sally the same thing over and over again about some clinical functions that I just do not understand. I have no clinical background whatsoever. And again, Sally can ask me about the same chart over and over again if it's not clear. And then by the same token, then I'll realise that that is not the right way to present that data. So I think really that is sort of the basis of our relationship, really, isn't it? That's how it works so well.
Yes, definitely. And I think keeping the jargon down and the pictures up. So, it's something that's simple, and then build, don't put us off, don't scare us until you've got your claws into us, and then you can start with something a bit more complicated. Find something that's going to appeal to us. If pitching wards or pitching departments so you can see that how different areas are doing, that's always good. Nurses in particular are terribly competitive, so anything where you can introduce something about we're better than you is good.
Thank you. I can see there's a question at the back here. I'll just run up with the mic. Meet halfway. There we go.
Thank you for that. Hi, my name is Sarah Parsons. I'm Health and Research Lead at HACA, which is the Housing Association's charitable trust. Shame we didn't get round to talk about the home side of it, because that obviously came in your big category. I assume a lot of that is about getting packages of care in, and also, obviously, we're seeing our work between health and social housing. Often it's a case of getting them back out into suitable accommodation. Just a couple of things that we sort of come across a lot. Potentially, massive impact can be done by the data that you're collecting on admission around patient tenure. So having that information up front, which then can feed into, certainly if the person is social housing, etc., having the linking with the community teams that are there. But then also, and I don't know if you're aware of this, but there are trusts now, and Sussex is one of them, where they're employing housing teams, housing workers as employed by health, but then they'll go out and they'll be based in the local authorities and they work in with the patients and then going out into the local authorities to make sure that the patients are ready to go out. I'm just wondering if that's something you've considered or experienced of or are aware of.
If my colleagues were here from our integrated discharge team who deal with the complex side, I'd just deal with the easy patients who are going to go home to their own homes that aren't infested with bed bugs, hopefully. But definitely, that's, you know, we've got to link in better all of those things. Discharge can feel very emotive. We can feel that we're pushing people out if we talk about it too early, which is daft, isn't it? We need to find out what home's like and prepare people to get back there as quickly as possible. So that's a brilliant idea. Housing in the boroughs we deal with, you know, a lot of home will be there isn't a home. Patients are homeless, living in unsuitable accommodation. So, yeah, that's a really fascinating.
Yeah, sorry. Ooh. I was just going to say, just to the point about getting them out quickly enough, and I think they certainly shouldn't be scared, because if it's not dealt with, you know, in some areas they're having to make patients homeless in order to get them into suitable accommodation. And if they want to go home to the same home, that's what we've got to tackle. But just also to say, it's something that can make a really quick difference. So in a hospital whereby 50% of delays in discharge were due to housing, just by bringing in the housing workers, they got that down within 12 months to by 50% to 25%, and then within 2 years there are now no delays due to housing.
It'd be really great to catch up about that. We've got to dash for a train, so you know, please contact us if you want to know more information, but I'd be great to get in touch with you. Is Sarah? Yeah, lovely. That'd be brilliant. Okay, thank you so much.
Thanks very much. Are there any, I know that it's a need for a train dash, but I'll just try and sneak one more question in, if that's all right. Is there any other questions in the room? All right, okay. Should have stayed over there.
Thanks. Rupert Chaplin, Data Science at NHS England. It's such a powerful way of working together that you've obviously got there, and I guess a lot of that comes from the dynamic and level of trust that you've got between each other. But how common is this at UCLH, or do you have any thoughts on how the model that you two have got, how do we scale that and encourage that elsewhere?
I'm not sure how common it is. There's definitely is, you know, if you're friendly and you're approachable, then that goes a long way. And UCLH is one of those places where lots of people have worked there for quite a long while, and so people move jobs, but maybe you get to know people. A lot of the stuff I've seen, to be honest, today and yesterday has been so fascinating, but doesn't quite feel real, if I'm honest. So definitely keep it real, data analysts, is what I'd say. That's what should be on the mugs next year.
And I'd just like to say on that as well, I think since we did set up the corporate analytics function at UCLH, then it's a very small team, and we are just sort of getting going with the data science side of things, as we say, but that has kind of bought us some space to be able to, as a small team, work with clinicians and go out and actually see what's happening on the front line and build these relationships more. Of course, on the clinical side, there's probably less time to be able to do that, but I think once you can start showing the importance of these relationships, as hopefully we do, then it does kind of make it easier to be able to find that time to do that.
Having a snazzy EHRS helps, because you can pull out so much data from it, and it's data that clinical people have put in often, so that keeps it real. But also having Zella as you know, as part of our team now embedded with us in Flow, that really helps as well, because it helps us not be quite so scared about the data.